Thank you very much. Thank you, Sridhar. Thank you, Dr. Polin, and thank you, Dr. News. Dr. Polin, is early morning for you and Dr. Joseph News. Thanks a lot for accepting our invitation. But by the way, it is your conference. It's like a little bit virtual, but inshallah we will move back to in person. So we have a lot of questions. I will ask if Sridhar, you will start with the question answer session, and then we will chip in with me and Aiman.
Thank you. I mean, it was an excellent session, and thank you for the opportunity to chair the session with the standards as well. Sorry?
Okay. Sure, go ahead.
Yeah. So, I mean, we missed Professor Polin for the previous session on infection. And so, I mean, NEC and infection are not far apart. So please feel free to chip in anytime you have a comment related to the NEC questions as well. We will start with Professor Joseph in terms of the models. I mean, it's very fascinating. I mean, we have different models we have designed for example, oxygen. I mean, the oxygen targeting through the ventilator, where it's a feedback system, closed loop system. We have the HERO score for infection, where the vital sign parameters are set up in artificial intelligence. But the main criticism of that is the algorithm depends on the person who's designing it. And so, I mean, here obviously an expert like you is involved and it will work well. And again, it's not the same problem for every baby. So how well can you differentiate in different settings? We had the Helix trial results where it shows that cooling in developing countries isn't as easy. We discussed that yesterday, and Dr. Junaid made a comment on that. So population differences will be there, the microbiome differences will be there. So do you think we will get an algorithm which fits different settings in a different way?
So I don't have a crystal ball, and I can't predict the future definitively, but I can say that we are making tremendous strides. Still just at the very beginning. Neonatology is actually lagging behind some of the other areas of medicine, for example, cancer, where artificial intelligence is making huge strides. So I'm hoping that we begin to pay more attention to this, and we develop the right collaborations with the bioinformaticians and the people who are doing the basic work in this area, so that we can make these strides in the future.
Thank you. And Professor Polin, I mean, a question on the breastfeeding in terms of anxiety related to the blood sugar level. I mean, if it's a primigravida mother or a post-cesarean mother, we often have a period when the milk output is low, and that's one of the reasons anxiety comes up. So would you consider the definition any different? I mean, obviously you showed slides as well where the formula-fed babies had a better sugar level, but the breastfed babies had more ketone bodies. But did anyone look at the milk output compared to the sugar level targeting?
So, first of all, it's great to see my friends who I haven't seen for a long time. So, Aiman, Junaid, it's so great to see you, even if it's virtual. So, you're right. The initial output from the breast is very small, a small amount of colostrum. But even with that small amount of colostrum, the the ketone bodies are higher. And babies are able to maintain their glucose values within an acceptable range. If they're asymptomatic and have a low glucose value, and some of them get quite low, I believe it's not of any clinical significance. So in a healthy breastfed baby, we do not monitor glucose values. If it falls into one of the high-risk categories, we do. But even a small amount of breast milk probably increases ketone bodies.
Question to Dr. Polin. First of all, thank you very much for joining us. And I know it's early in the morning for you, and we woke you up early, so apologize. We hope to see you in Abu Dhabi next time.
Absolutely.
Baby Kim, that you mentioned in your example. No, the baby Kim who had hypoglycemia, and check sugar was at 2 hours was 24. Now, if baby Kim does not have any risk factor, we're not going to check his sugar, right? I mean, do you check sugar for all babies, or we just selectively check sugars on baby who are high risk?
Just selectively choose babies who are high risk. Probably the most common mistake that we make here at Columbia is someone gets a glucose value at 1 or 2 hours of life and it's low. And that initiates a whole sequence of responses, check it again, give glucose, and it's during the time of biochemical hypoglycemia. So we try not to check, we don't check glucose values unless it's a high risk baby.
Right. And those numbers that you mentioned, are they numbered for first 48 hours, which is going to be different after the third and fourth day, right?
Yes, they go up spontaneously. Third, fourth, fifth day values, babies go up to a normative value, which is higher.
Right. Right, great. Dr. Josef New, they mentioned this example about intestinal perforation, spontaneous intestinal perforation. Now, you mentioned that, we take him to the OR and we did the surgery, so the baby did well. But now the standard for, from our surgeon point of view, is not to take the baby to surgery with intestinal perforation as the first line. So they put, a Penrose drain for 2 or 3 days, and then they take surgery. So with that, in the context of intestinal perforation without neck, would that be in the best interest of the baby, or should we take those babies if we have high suspicion of intestinal perforation without neck to take them surgery right away?
So I think that there's still some controversy about that, and certainly you see different surgeons having different opinions on that. The studies that have been done, so for example, in the early 2000s, Dr. Randy Moss from Yale, pediatric surgeon, led these studies that looked at, they called it necrotizing enterocolitis and placing a drain versus doing a laparotomy, and found no difference. There's some work that was done by Dr. Piero and colleagues in Canada that showed that there may be a little bit of a difference. And then there's some studies suggesting that if you just put in a drain and if there's pus in the gastrointestinal tract or intestinal contents in the peritoneal cavity, that may actually lead to neurodevelopmental consequences. And Dr. Martin Blakely has been doing some studies in that area. So this is still controversial. And one of the problems is that placing the drain also, and this is a point that I try to make here, placing the drain doesn't tell us if this is necrotizing enterocolitis or spontaneous intestinal perforation. And many of those babies get coded as having necrotizing enterocolitis, and that gets put into our data set. And so that really causes a very, I would say, dirty data set for our for purposes of epidemiologic studies in the future.
Okay. Yes, Sridhar, I have few questions. So it's actually both Dr. Polin and Dr. Nu, both of you, because Dr. Polin also have a lot of work on the NEC, and NEC is a very controversial and a hot topic here in this region. So first thing about both of you, if you can comment, because on probiotics, is now a standard of care, or if you are using it, or it's a lot of, I mean, hype here about the use of probiotic to prevent NEC. If both of you can comment.
I'll make a small comment. So if you look at all the probiotic studies, and some of them are well done, randomized trials, others are not, it looks like that probiotics decrease NEC, but there's a great heterogeneity in the composition of those probiotics. And it's hard to extrapolate one combination of probiotics like bifidobacterium in one study with another probiotic in another study. So the data are very dirty, but overall, it looks like probiotics decrease NEC. It overall looks like probiotics are safe, but there has been probiotic sepsis and a couple of outbreaks of fungal sepsis at Yale, or at least one outbreak of fungal sepsis at Yale. And there have been about 5 studies examining the composition of probiotics, and what you see on the label often does not match what you think you're giving to the baby. So when it's analyzed, the probiotics may not contain what you think you're delivering. And the last thing I'll say is that under 1,000 grams, there have been very few randomized clinical trials. And it's not clear that probiotics decrease NEC in the highest risk population. And that's all I'll say. Joe knows a lot about this topic, so I'm sure he's got some comments.
Yeah.
I think, Rich, you answered 90% of it right there, which is great. About in the United States, about 15% of the neonatology and the neonatal intensive care units are using probiotics. 15%, 15. And there's a recent review and commentary by Brenda Poindexter from the American Academy of Pediatrics recommending against the routine use of probiotics at this time. And for many of the reasons that Rich mentioned, I think if you consider it in this way, antibiotics decrease infections, but which antibiotic are you going to use for a certain infection? We need to have a specific microbial therapeutic measure that actually works. And which one do we really use? So that's one point. Which one really works? We can't just say probiotics because there's 250 of them at least. Okay. The other point is that if we are going to use a probiotic for prevention of a disease, we should really take into consideration what the European and the American regulatory agents say is a pharmacologic agent versus a food. And if you are talking about prevention of a disease, we are talking about a pharmacologic agent. A pharmacologic agent needs to be put in under very rigorous standards in terms of its cleanliness, in terms of its purity. And this is not the case for most of the probiotics, as Rich already mentioned. And we've had some cases such as that Yale case where a baby died of mucormycosis, probably based on the fact that this was not a pure preparation. So I think we need to be somewhat careful with going forward with the routine use of probiotic.
So in relation to that, with your permission, Sridhar, if I continue, sorry about that. In relation to that, you all know about this new product which is called human milk fortifier and human milk itself with the prolacta. What do you think? Because here still the breastfeeding rate is not that great, and exclusive breastfeeding, and especially when we are fortifying with the cow milk protein. If instead of this cow milk protein, if we use the human milk, I need again both of you, sir.
Go ahead, Rich.
So anyway, I now view the human milk fortifier as sort of a gimmicky thing, and the data for me are not convincing that changing from a bovine-derived fortifier to a human milk-based fortifier has any clinical importance. The one meta-analysis I've seen had just 2 studies in it, so it's not really a meta-analysis. So I'm not a big proponent of spending the dollars. In fact, we don't use the human milk fortifier in New York. You may feel differently.
The same holds for us, and I totally agree with Rich. The one large study that was done that was not supported by a company, this was a study that was done in Canada. The data was very unconvincing that the prolacta, the humanized milk fortifier was very helpful.
Okay, Aiman or Sridhar, you have, otherwise I have few more.
Actually,
have one question, yeah.
The question about humanized human milk fortifier or humanized milk, we don't use it. I think their most recent meta-analysis did not show really a lot of difference between, bovine and human milk in terms of like severe neck. I mean, maybe the milder form of neck is a little bit different.
Let me just interject. I'm sorry, let me just interject. And that's a really interesting point, because the milder form of neck could just be simply feeding intolerance.
I think in our unit, we are considering using it only for the suspected F-pies kind of presentation, where you don't want a cow's milk product. So this is the current understanding. We haven't actually used it so far. I mean, I have a question again, just very important point again to project what you said about the feeding algorithms and not to be very bound down by the volumes. So, I mean, most of the units in the very small babies, we start with 15 ml per kilo, and we are very reluctant to go up. So the point I want to stress, and I want your opinion on that as well, is you may start with a lower volume for the first 2-3 days, but once you start tolerating it, we can go comfortably, because you showed the studies and the Cochrane analysis currently confirms the same as well. So would you agree that we start in the extreme low birth weight babies with a smaller, slower rate, but once we know they are tolerating, we can go up faster? I mean, the same baby, we don't need to stick to the same number.
Joe, that's a question for you, but
yeah, I think that the studies that we have available to us, especially that recent study from the UK, does support what you just said, that you can go up more rapidly. You could probably go up more rapidly even at the very beginning, but to take that cautious approach in these, very sick preterm babies, I think is very reasonable. I don't have any problem with that. I see a lot of good rationale behind that. And that's really what we do too, is in some of our really sick preterm babies, we will not start with 30 and advance at 30, 35 every day. But again, I agree with that approach.
Thank you.
So
I have a question actually for Dr. New.
Sure, go ahead.
About the residuals. I mean, we always in a constant fight with our nursing colleagues about not to check residuals, but they insist that this is a nursing practice and they cannot really change it. And whenever we get the 2 mLs of residuals, everybody start especially in the 3 in the morning when you have one fellow at night and you want to kind of get some sleep without being interrupted. So what's the and the other thing is abdominal girth. I know if you didn't comment about abdominal girth, I think this is another useless thing to do for evaluating feeding tolerance. But what's the conditions of that? You say, okay, now we have to check residuals. Now for us, it's like abdominal distension, bilious vomiting, or maybe looking sick otherwise. Anything else that we will say, this is now to check residuals?
Yeah, and I think that you hit some of the main points right there. The studies that we did were really, and the recommendations that we made with those studies is routine gastric residual checks. But that doesn't mean that you should never check gastric residuals. So if you are concerned about the baby, if there is something going on that you are concerned about, I think it's reasonable to do a gastric residual check. And you mentioned some of those conditions.
Joe, I have a question for you. It's about a baby I'm caring for right now in my NICU. Who baby had 1 episode of emesis. They checked the gastric residual. We gave 2 and we got back 5. So they checked it again. We gave 2 and we got back 5. What do you do about those babies? You're getting out way more than you're putting in.
That's a situation that I think you have to question what is really going on in that baby. Is that just simply feeding intolerance? Is that something else going on where the baby may have an obstruction? And we do see some babies who have had very small perforation or some adhesions or stricture that may cause this, or it's just a lack of motility. whether it's necessary to continue to check gastric residuals in a baby like that. If you see it a couple times and if the baby seems to be tolerating the feedings, stop checking them. I would not continue to check that.
That's what we did.
Yeah.
Okay. I have Sridhar, with your permission, I have 2-3 questions for Dr. Polin. One from your previous talk. You mentioned about symptomatic and asymptomatic babies. Here, baby delivered full term with no risk factor, but he has some respiratory distress, and they put him on high flow or low flow nasal cannula. Baby is fine, everything is okay. But they did the screening and start antibiotic. What is your comment? Did you consider him symptomatic or asymptomatic?
So in the mildly symptomatic baby, the kid who has some respiratory distress, low flow nasal cannula, who looks active and well, we generally do not start antibiotics. We just, the term I would use, very non-specific, is delayed physiologic transition. So either the fluid is not being absorbed from the lung, or there's a little increased pulmonary vascular resistance, so they need a little more O2. But in general, we do not treat those babies. If the baby looks ill to you and sepsis is a possibility, then obviously we go ahead and treat those babies.
Okay. The other question about the duration of antibiotics and most of the cases, we discussed about 48-hour culture or 36-hour culture. And Karen was there in the live discussion, and he said, if you are sure that your lab can do 36 hours, then you can stop. What is your recommendation on this about 36 to 48 hours?
So 36 is our standard, and I think the new techniques can pick up any growth. I think they say 90% of cultures will be positive at 24 hours, 98% by 36 hours. So we use 36 hours as our standard. But I think in a year or two, you may hear that with new techniques, 24 hours will become the standard. And the less you can give antibiotics based on everything that Joe New said, which changes the microbiome, I think babies are better off.
So similar question to this for Dr. Polin and Dr. No, that let's say you have a pneumatosis, you put him on drip on 7 days. Now you have to start 7 days antibiotic, anaerobic, 1 gram negative, 1 gram positive, a set of 3 antibiotics, or both of you.
Joe, why don't you answer that? I'll chime in here.
Yeah, I don't think we really know what you're saying. There is a very conservative approach, but I think that what we are considering, this conservative approach, may actually lead to more harm than good in a large number of our babies. And what we need to do is learn more about what is really going on in the GI tracts of these babies so we can actually develop a more precision-based approach. But I don't think we've got a really good answer for that. And right now, I'm very concerned about this automatic knee-jerk approach where every single baby has to have at least 7 days of antibiotics and suction and NPO because they've had this questionable pneumatosis on X-ray.
So I ask myself, why are we giving antibiotics? I'm giving antibiotics because of suspected bacteremia? Well, that for me is a 48-hour rule out. If the baby is clinically ill, obviously I'm going to treat that baby with antibiotics, not knowing what's going on in the GI tract. There's a lot of inflammation, risk of more translocation, bacteremia. But if a baby is getting better at 48 hours and blood cultures are negative, I'm not sure there's a need to give prolonged broad spectrum antibiotics beyond that.
That's right. One more question to Dr. Polin about the hypoglycemia. Let's say the baby of the diabetic mother or infant of gestational diabetes, how long that hypoglycemia persists if there is no other endocrinology cause, only because of baby of DDM?
So if you're asking about infants of diabetic mothers, generally within 48 hours, most of those babies can maintain their glucoses in normal range. So that's a high risk group, and we would probably monitor those babies for that 48-hour time period, and if everything is okay, then stop.
Okay. If you allow me, because there is a question I'm receiving on the WhatsApp also. Again, for both of you regarding the blood transfusion and the neck. So what is your practice that you are doing blood transfusion, you hold the feeds, or you don't hold the feeds, something like that?
So I always say that the evidence or science does not say that withholding feeds or that giving feeds during a transfusion is going to cause necrotizing enterocolitis. So I tell my nurses, I would recommend not withholding feeds, continuing feedings, but my nurses say, well, we're really concerned, and we have a guideline or a protocol that says withhold feeds. So I acquiesce to my nurses, just as I'm sure you do.
That's a standard. That's standard practice.
Okay.
That's standard practice. Now,
Actually, in our neonatal, we've been able to convince our nurses otherwise, where we actually feed during the transfusions. It's
you.
Yes.
Okay.
You have a good group of nurses. You're recruiting for neonatologists?
Okay, the last question from my side, it is the actually for Dr. Josef Nu, and it is from the Italy. Dr. Paolo Manzoni asked you the lactoferrin and the neck. Comment on that.
Yeah, I don't think that the studies that have been done with lactoferrin are clean enough studies to be able to say that lactoferrin prevents necrotizing enterocolitis and that we should be using it routinely. The studies that we have, I think, are not adequately powered. They are not the types of studies that I would use to support routine use.
I know we are running out of time. Can I ask one quick clinical question in terms of, I mean, is there any gestation you would pitch and say, I mean, from this stage, if the baby is clinically well and sugar is normal, we can go for full feeds from day one? So I practically do it about 32 weeks. I mean, obviously we won't have full breast milk, but if the parents consent till we get breast milk to give alternative options. So would you consider that, or would you go for a more conservative approach?
I think we can move fairly rapidly in those babies greater than 32 weeks gestation. So I would tend to agree with getting up to full feedings fairly quickly in those babies.
But I think we're running out of time, but it's up to you if you have any more questions.
No, that's okay, because we have other speakers. So thanks a lot from my side, Dr. Nu, Dr. Polin, and definitely, and Dr. Ola is also listening us. So all three of you, inshallah, will be in Abu Dhabi next year. Sridhar,
Great seeing all of you.
Thank you. Thank you. Nice to meet you.
Stay well, everybody.
Yeah, bye-bye.
Thank you. Sridhar, thanks a lot. Thanks a lot.
Thank you so much. Thank you for the opportunity.
Thank you.
Thank you all.
Thank you.